Taking amlodipine, Losartan, or lisinopril for blood pressure. Here's what many seniors don't know. For countless individuals, the morning ritual of taking a blood pressure medication, whether it's amlodipine, Losartan, or lisinopril, has become an ingrained, almost automatic part of daily life. For a year, or perhaps even longer, this small pill represents a cornerstone of their health management, a silent sentinel against the invisible threat of hypertension. Yet, as Dr. William emphasizes, the critical question often remains unaddressed. How deeply do individuals truly comprehend the intricate dance these powerful pharmaceuticals perform within their bodies? It's not merely about reading the one-line description on a pharmacy label or vaguely recalling a brief explanation from a busy doctor. True understanding delves into the nuanced mechanisms of action, the subtle ways these drugs can interact with an individual's unique physiology under specific conditions, and the crucial warning signs that differentiate a minor, manageable side effect from a potentially urgent medical situation. The vast majority of people, even those who are educated, meticulous with their finances, and diligent about staying informed, often hesitate when confronted with this question, a pause that speaks volumes about the widespread knowledge gap. These are not benign vitamins or gentle supplements. Amlodipine, Losartan, and lisinopril are potent pharmacological agents designed to profoundly alter the fundamental functioning of the heart, blood vessels, and kidneys, day in and day out. Despite their profound impact, millions of older adults navigate their regimen on autopilot, often without a comprehensive grasp of what specific bodily signals to monitor, what environmental or dietary factors to avoid, or when an otherwise ordinary sensation might actually be a critical message their body is desperately attempting to transmit. This channel, and Dr. Williams' mission, is dedicated to bridging this information chasm, providing clear, practical, and candid health insights that are frequently omitted from the constrained timeframes of a typical 10-minute doctor's consultation. By the conclusion of this discussion, the aim is for every individual to possess an enhanced understanding of these three vital medications, empowering them to feel significantly safer, more confident in their self-management, and substantially less susceptible to being caught unaware by unexpected developments. The story of Walter, a sharp and methodical 74-year-old former engineer, serves as a poignant illustration of this critical need for deeper understanding, setting the stage for the comprehensive insights that follow. Walter meticulously adhered to his prescribed medication schedule, a habit his daughter had diligently supported by setting up a pill organizer, which he managed with the precision of a project timeline. When amlodipine was incorporated into his regimen, his logical, engineering mind assumed it was simply one more blood pressure pill, belonging to the same therapeutic category, albeit with a different name. This seemingly innocuous assumption, however, nearly cost him a significant and productive portion of his life. Approximately 3 months after starting amlodipine, Walter began experiencing profound changes. His feet swelled to the extent that none of his regular shoes fit. His legs felt perpetually heavy by late afternoon, and the simple act of walking exacerbated his discomfort, leading him to drastically limit his physical activity. Understandably, fear began to creep in, prompting him to confide in his son that he suspected his circulation was failing, even leading him down the alarming rabbit hole of Googling heart failure. The actual explanation, however, was far less dire and significantly more manageable. Yet it remained a mystery to Walter because the fundamental distinctions between amlodipine, Losartan, and lisinopril had never been adequately clarified. While all three medications effectively lower blood pressure, their mechanisms of action diverge dramatically. Amlodipine, a calcium channel blocker, operates by inducing relaxation in the walls of the blood vessels, particularly the smooth muscle within the arteries, thereby reducing vascular resistance and allowing blood to flow more freely. Lisinopril, an ACE inhibitor, targets and blocks a specific enzyme in the body responsible for constricting blood vessels, leading to a reduction in pressure. Losartan, an angiotensin receptor blocker, ARB, acts within a similar physiological pathway, but engages a slightly different receptor, a distinction that carries more weight than often realized. These three distinct pharmacological approaches lead to unique side effect profiles and necessitate vigilance for different warning signs. Grasping these fundamental differences is paramount, as it transforms how one interprets the body's signals, moving away from a simplistic, one-size-fits-all perspective. Walter's swelling was not an ominous sign of impending heart failure, but rather a predictable physiological consequence of amlodipine working precisely as it does in a considerable percentage of patients, effectively relaxing the arteries to a greater degree than the veins, which, in turn, causes fluid to accumulate in the lower extremities. Once this specific cause was accurately identified and appropriately addressed, Walter swiftly regained his mobility, returning to his walking shoes within a matter of weeks. The name emblazoned on a medication bottle is far more than a mere label. It signifies a therapeutic category, and it is within this category that the characteristic patterns of action and potential side effects are revealed. Delving further into this topic, the leg swelling associated with amlodipine stands out as one of the most frequently misunderstood side effects in the realm of blood pressure management, impacting a surprisingly large cohort of patients. The underlying physiological process is straightforward. When amlodipine facilitates the relaxation of the small arteries in the legs, blood flows into them with greater ease. However, the veins, which are responsible for returning blood to the heart, do not relax to the same extent, creating an imbalance. This discrepancy results in more blood entering the lower extremities than exiting, leading to a buildup of pressure within the tiny vessels near the ankles and feet. This elevated pressure subsequently forces fluid out of the vessels and into the surrounding tissues, manifesting as puffy ankles, socks that leave deep, lasting indentations, shoes that suddenly feel too tight, and a sensation of heaviness and fullness in the legs, particularly by late afternoon. Crucially, this type of swelling is typically not an indication of fluid retention caused by excessive salt intake, nor does it signal kidney failure or the onset of heart failure. In the vast majority of cases, it represents a predictable and direct physiological response to the mechanism of amlodipine. The genuinely dangerous aspect of this phenomenon lies not in the swelling itself, but in how individuals often react to it. Some, upon observing the swelling, unilaterally decide to discontinue their medication without consulting their physician, leading to a silent and potentially perilous rebound in their blood pressure, while under the mistaken impression that they have made a sensible health decision. Others continue the medication but, believing they are retaining water, drastically reduce their fluid intake, a counterproductive and dangerous choice that can lead to dehydration, which itself carries significant risks when on a calcium channel blocker. Still others, much like Walter, silently endure the discomfort for months, progressively curtailing their activity levels, resigning themselves to what they assume is a worsening condition, and unnecessarily sacrificing their quality of life. The appropriate and critical course of action, one that every patient should commit to memory, is to initiate a conversation with their doctor about any leg swelling experienced while taking amlodipine. This dialogue is essential, not because the medication is inherently wrong for them, but because it opens the door to potential adjustments in dosage, exploration of alternative medications, or implementation of specific strategies, such as leg elevation, precise timing of doses, or a reconsideration of which blood pressure medication is best suited for their individual body, that can render the side effect far more manageable. None of these beneficial interventions can occur if the patient suffers in silence. Moving beyond amlodipine, the discussion turns to lisinopril and its most infamous side effect within the ACE inhibitor class, the persistent cough. This is typically not a wet, productive cough, but rather a dry, scratchy, and relentless tickle originating in the back of the throat. It often worsens at night and frustratingly fails to respond to common remedies like cough drops, lozenges, antihistamines, or any other usual occupant of the medicine cabinet. What makes this particular side effect so insidious is its often delayed onset. While some individuals may experience it within the first week of starting the medication, others might go 3 or 4 months before the cough appears. By this point, the connection to lisinopril rarely even crosses their mind. They have been on the medication for an extended period without issue, leading them to attribute the cough to environmental factors like dust, seasonal allergies, a lingering irritation post-cold, or even acid reflux. Evelyn, a 71-year-old avid gardener, exemplifies this scenario perfectly. When her cough began in late spring, she naturally assumed it was a consequence of her time spent outdoors during pollen season, a logical conclusion given the timing. She tried antihistamines, invested in an air purifier, and even mentioned it to her primary doctor, who ordered a chest X-ray that returned clear. 6 months later, the cough persisted, disrupting her sleep nearly every night, leaving her perpetually tired, irritable, and increasingly convinced that a serious medical issue was being overlooked. Upon her visit to Dr. William, one of the first questions posed was, "When did you start Lisinopril relative to when the cough appeared?" Evelyn paused, pulled out her phone, and began to calculate. She had initiated Lisinopril 11 months prior to their consultation, and the cough had emerged approximately 4 months into her treatment. The connection, surprisingly, had never been made. Once the probable cause was identified, and in collaboration with her primary physician, she transitioned to Losartan, a medication targeting a similar mechanism but without this specific cough side effect. The bothersome tickle in her throat vanished within 2 weeks. 11 months of disrupted sleep and diminished quality of life were resolved in just 14 days, simply by connecting the previously disparate dots. However, a critically important distinction must be made here, drawing a very clear line between a mere nuisance and an absolute medical emergency within the ACE inhibitor category. If an individual taking Lisinopril develops any swelling of the lips, tongue, face, or throat, particularly if it is accompanied by difficulty swallowing or breathing, immediate action is paramount. This is not a situation for waiting until the next day, calling the doctor's office, or attempting to self-treat with an antihistamine like Benadryl. This is a condition known as angioedema, a rare but very real and potentially life-threatening reaction that can rapidly constrict the airway. A dry cough is an inconvenience. Throat swelling is an emergency. The vast gulf between these two symptoms is a vital piece of information that every patient must commit to memory for their own safety and the safety of their loved ones. If this level of detailed clarity regarding blood pressure medication has not been previously encountered, engaging with such information is a crucial step towards safer health management. The focus now shifts to Losartan and a particularly striking danger, precisely because it often arises not from doing something wrong, but from individuals earnestly attempting to do what they believe is right. Losartan, similar to Lisinopril, exerts its effects on the renin-angiotensin system, a sophisticated pathway responsible for regulating the body's blood pressure. One well-documented effect of this class of medication is its potential to elevate potassium levels in the blood. For the majority of individuals, when appropriately monitored, these potassium levels typically remain within a safe and acceptable range. However, the scenario changes dramatically when certain common lifestyle choices are layered on top of this medication. Herein lies the counterintuitive twist. Potassium is not solely found in well-known sources like bananas or prescribed supplements. It is cunningly hidden in numerous products that are actively marketed and perceived as healthier alternatives, most notably salt substitutes. Many popular low-sodium salt alternatives, readily available next to regular table salt and frequently branded with heart-healthy labels, achieve their reduced sodium content by replacing sodium chloride with potassium chloride. Thus, a well-meaning senior, having been advised to restrict their salt intake for cardiovascular health, purchases a potassium-based substitute, uses it liberally across all their meals, and inadvertently begins to flood their system with additional potassium, while simultaneously taking a medication that independently contributes to elevated potassium levels. This dangerous combination can push blood potassium levels high enough to significantly disrupt the electrical system of the heart. What makes this situation especially perilous is that elevated potassium does not always manifest with dramatic, screaming symptoms. Instead, it often announces its presence subtly, through unusual muscle weakness, a persistent, unexplained fatigue, a cramping sensation in the legs, tingling in the hands or feet, or a fluttering, irregular heartbeat. In some cases, there may be almost no noticeable symptoms at all, right up until the point when serious, life-threatening cardiac complications arise. It is imperative to consider individuals in one's life, perhaps even oneself, who have transitioned to a salt substitute within the past year or two. If that individual is concurrently taking Losartan or Lisinopril, this warrants an immediate and serious conversation with their doctor. This is not to suggest that the medication is inherently dangerous in isolation, nor that potassium-rich foods are inherently harmful. Rather, it highlights that the specific combination, when lacking awareness and routine monitoring, can silently create a slowly escalating problem that is entirely preventable. Furthermore, the risk extends beyond salt substitutes. Electrolyte powders, certain meal replacement shakes, and various over-the-counter sports recovery drinks also contain meaningful concentrations of potassium. Because these are not prescription products, they are rarely mentioned during routine medical consultations, and it is precisely this oversight that makes them potential contributors to a hazardous potassium imbalance. Beyond specific drug-related considerations, a critical scenario that rarely receives adequate attention in discussions surrounding blood pressure medications, yet disproportionately impacts seniors, involves the body's response during illness. It doesn't require a severe illness or hospitalization. Even a common stomach bug, a few days of persistent vomiting or unremitting diarrhea, a transient loss of appetite for a couple of days, or simply a prolonged hot spell in summer accompanied by heavy sweating and insufficient fluid intake, can drastically alter the body's internal environment. When dehydration occurs for any reason, the exact same dose of Losartan or Lisinopril that was meticulously calibrated for a well-hydrated system can behave dramatically differently. The consequences can include a dangerously precipitous drop in blood pressure, while the kidneys, already under increased strain from fluid loss, become acutely vulnerable. Symptoms such as dizziness, generalized weakness, faintness, or even acute kidney strain can emerge far more rapidly than most people anticipate. The medication itself has not changed. Rather, the body's internal milieu has shifted, and the drug is now operating under conditions for which it was not designed. This insight represents one of the most vital, practical pieces of information for daily health management. Illness fundamentally changes the rules. If a patient does not possess a clear sick day plan, a pre-established understanding of whether to temporarily hold a dose, when to contact their doctor, and which specific symptoms should trigger an urgent medical visit, they are leaving a significant and dangerous gap in their safety net. This crucial plan should be explicitly discussed and provided by the prescribing doctor well in advance of any need. If such guidance is lacking, it is imperative to proactively ask at the next appointment, what should I do with my blood pressure medication if I develop a stomach virus or find myself unable to keep down food and fluids? This seemingly simple question is among the most important one can pose, yet it remains one of the least commonly asked. Furthermore, another frequently overlooked interaction occurs when common over-the-counter pain relievers intersect with blood pressure medications. Consider a scenario: a challenging week, an arthritis flare-up, aching knees, a stiff back. The natural inclination is to reach for ibuprofen or naproxen, a familiar over-the-counter anti-inflammatory medication used for years, perceived as innocuous. However, when these NSAIDs are taken regularly by someone also on lisinopril or losartan, potentially a diuretic, a water pill for fluid management, a critical danger emerges. This particular combination, especially with consistent use, can significantly diminish blood flow to the kidneys. In the context of even mild dehydration, the risk of acute kidney injury escalates substantially. This is not a rare hypothetical occurrence. It is one of the most common yet preventable clinical situations encountered. The primary reason it often goes unnoticed is that patients typically do not categorize ibuprofen, naproxen, or similar over-the-counter anti-inflammatory drugs as real medications in the same league as their prescription drugs. They are simply something from the drugstore for the pain. Yet the kidneys, devoid of such distinctions, respond solely to the underlying chemistry. Therefore, if anti-inflammatory pain medications are routinely used for chronic conditions like arthritis, joint pain, or back pain, and any of these three blood pressure drugs are also being taken, an immediate discussion with a healthcare provider is essential. Often, safer alternatives exist, such as acetaminophen, various topical pain treatments, physical therapy modalities, or other options that do not carry the same kidney-related risks. Patients should not feel compelled to simply endure pain or silently accept such risks. A better, safer path is almost always available, requiring only professional guidance to discover. Finally, a phenomenon that might seem minor but carries significant weight, especially for older adults, is dizziness. That brief, unsettling, wobbling sensation upon rising quickly from a seated position on the couch or getting out of bed in the morning, the world momentarily tilting, prompting a quick grab for a doorframe, is a common, often dismissed experience. For many seniors on blood pressure medications, this lightheadedness is a regular occurrence. Yet it is almost universally underreported because it seems too trivial to mention. However, it is crucial to understand that in older adults, even a fleeting few seconds of dizziness can be sufficient to precipitate a fall. And a fall, particularly one resulting in a hip fracture, possesses the devastating potential to derail an older adult's overall health trajectory in ways that can take years to recover from, if full recovery is achieved at all. This is not alarmism. It is the unforgiving intersection of physics and biology, a reality that demands profound respect. The underlying cause of this dizziness is, paradoxically, the blood pressure medications effectively performing their job, lowering blood pressure. When an individual stands up rapidly, the cardiovascular system has not had sufficient time to compensate for the sudden change in position. Consequently, blood pressure briefly drops, and blood flow to the brain momentarily decreases, which is experienced as that familiar, lightheaded, tilting sensation. The immediate fix is often quite simple: rise slowly. Take a moment to sit on the edge of the bed before attempting to stand fully. Hold on to a stable object when getting up, allowing the body a few extra seconds to adjust to the change in posture. However, beyond these practical adjustments, persistent dizziness that occurs regularly, dizziness that does not improve after the initial few weeks of starting a medication, or any episode of near fainting are unequivocally signals that warrant a serious conversation with a healthcare provider. The medication dose may need adjustment. The combination of drugs might require review, or changes to hydration habits could be necessary. Silence on this particular issue is not merely a small risk. It is a significant potential threat to safety and independence. Furthermore, much unnecessary anxiety and, occasionally, dangerous impulsive decisions stem from how people manage blood pressure at home. It is vital to internalize that blood pressure is not a static, fixed number. It fluctuates incessantly throughout every hour of every day, responding to a myriad of variables: the quality of sleep, recent caffeine intake, the presence of pain, anxiety levels about the reading itself, whether one has just come indoors from outside, or even if one has spoken loudly just prior to taking a measurement. A solitary high reading on a random Tuesday morning after a restless night does not automatically signify that a medication is failing. Conversely, a single low reading after a hot, dehydrating day does not indicate that the medication is suddenly too potent. What truly matters, and what provides meaningful clinical insight, is the pattern of blood pressure readings observed over time, measured consistently, using the same arm at the same time of day after at least 5 minutes of quiet rest, without rushing or engaging in conversation. When individuals monitor their blood pressure inconsistently and react emotionally to individual readings, the subsequent decisions are almost invariably suboptimal. This can manifest as extra doses taken out of fear, skipped doses because one reading appeared favorable, or frantic, unnecessary calls to the doctor about a number that, when viewed in its proper context, was entirely unremarkable. The correct approach involves monitoring with a systematic method, tracking the readings diligently over time, bringing a detailed log to medical appointments, and allowing these objective patterns, rather than panic or isolated numbers, to guide the conversation with the healthcare provider. This fundamental shift in approach significantly reduces anxiety, leads to more informed and better decisions, and provides the doctor with far more useful information than a single, alarming screenshot from a home monitor. These essential medications, Amlodipine, Losartan, and Lisinopril, exert their therapeutic effects through a steady, consistent presence within the body's system, not through erratic spikes and gaps. They are not rescue medications, designed to be taken reactively like a pain reliever for an acute headache. Their efficacy and safety depend on consistent adherence to the prescribed regimen, avoiding extra doses driven by worry or skip doses based on a temporary feeling of well-being.